Hi, my name is Bobby Hayes, and I am the instructor for this class. I figure if you can't find a video that says what you wanted to say, you go ahead and create it. I'm a licensed mental health counselor and a certified addictions professional. I've been practicing in the field for well over 30 years, and I have a strong background both in working with addictions, eating disorders, relationship issues, and other mental health disorders. I'm making this video because I want you to understand the complexity of doing substance abuse treatment, but also doing mental health counseling. One of the areas that we oftentimes have the most difficulty is being able to differentiate between substance abuse disorders and other mental health issues. In fact, the problem is that we oftentimes will rely on patient information in order to be able to make an appropriate diagnosis. And one of the problems with being in the grips of disease of addiction is that we aren't willing to acknowledge the fact that we have it. So in separating out between what it is that we are seeing and what the person is telling us, it becomes very important to be able to understand the complexity of mental health issues. When a clinician is making a diagnosis, one of the first things they need to rule out is any kind of medical diagnosis. I remember years ago my mom had she was in her 80s, and she had a urinary tract infection, which is not uncommon in the elderly. And one of the ways it manifests itself is that people who are elderly and they're having that kind of health issue become psychotic. And so my mom began hallucinating, and she saw my dogs visiting her in the emergency room, and she saw my father, who was deceased, visiting her in the emergency room. And anybody who was looking at my mom from what she was presenting at that time would have thought she was having a psychotic reaction. And in fact, it was a medical issue that was causing that kind of psychosis. Once the urinary tract infection cleared up, she was able to be totally lucid and appropriate. So one of the first things you want to do is you want to rule out any kind of medical issues that may be interfering with somebody's mental health coping strategies. The second thing you want to rule out is whether or not what you're seeing is related to substance abuse disorders. And again, it gets back to the idea that if we ask people about, are you using drugs or are you abusing alcohol, many people will say no, because denial is a hallmark feature in how a client is able to cope with what it is that they're doing. You know, I said this in an earlier PowerPoint, but there's nothing about addiction that makes sense. You know, if I'm addicted to crack cocaine and I'm spending all the family money on crack, there's nothing about that makes sense to somebody, and it's a logical behavior. So most of us look at that and we judge it because we don't understand it. But for somebody who's experiencing that firsthand, it becomes really problematic to be able to explain what really goes on, because being told by someone that you need to stop using crack is kind of like telling somebody that they have to stop breathing. That same feeling, claustrophobia of, oh my gosh, I can't do it. And so many times people will hide their relationship with alcohol and drugs when they're seeking services because they don't want to take a look at something that they may have to change. It becomes really important that we're able to ask the right questions, and that we're able to do so in a way that's non-threatening and non-judgmental. I oftentimes will find that when I'm doing a mental health evaluation that I may ask questions, and then I may gently go back to those questions later on and kind of ask again once I've been able to build a relationship with the client, because initially their resistance may be up and they may have difficulty being able to say what it is that's really going on for them. So what I'm encouraging you to do is take a look at learning as much as we can about addiction, how it plays itself in somebody's life, and how we ask the right questions to be able to diagnose, and how we are able to understand the comorbidity of mental health diagnoses and drug dependency. I remember one time I had a client, and he was, I evaluated him. He was in a psychiatric hospital at Memorial, and when I went to go see him, one of the things that became really clear is that he was bipolar, and he would regulate his bipolar is when somebody has vast mood fluctuations, so they can be very hypomanic, which is when they are very they believe that their engine is just running really faster than everybody else's, and they can't figure out why people can't keep up with them, and they oftentimes will do reckless behavior, and they'll overshop, and they'll overspend, and they'll drive fast, and they'll stay up all hours of the night, sometimes not sleeping for days. And this gentleman would control his mania by drinking. He had vowed to his wife that he was going to stop drinking, and he did. Unfortunately, when he did that, he had no mechanism for being able to stop his manic episodes, and so he spent 3 days and 3 nights taking all of the rocks in his rock garden and separating them out and putting them back in by size, shape, and color. He had bought floodlights for his front yard so that he could continue doing it throughout the night and not have to be stopped by darkness. And eventually his neighbors complained because it was so bright they couldn't sleep. And when the police came to see him, they found somebody who was very manic, and they hospitalized him. And one of the things that became clear is not only was the gentleman an alcoholic, but he was also somebody who was bipolar. We couldn't treat one without treating the other. If we were to treat his bipolar disorder, we had to do so understanding that he had used alcoholism as being a way of coping with his mania for many years. And so we had to begin to create an environment that we could treat both areas at the same time. It gets to be very complex. And one of the things that Chapter 1 talks about is that it's not reasonable to expect that we're going to know all things about all areas of mental health issues. That, if I'm working with somebody and they have sexual dysfunction, I'm not somebody that's their area of expertise. I know people who are, they have doctorates in sexology, because there's really a degree called that, and that's who I make referrals to, because they are more informed about the physiological manifestations of sexual dysfunction than I could be. If somebody is a mental health counselor only and they don't really have a background in addiction, they may refer to me because I have a background in treating addictive disorders. So it is about really being able to know not only where my expertise is and inviting myself to be able to learn more, but also then knowing where to refer to people when something becomes more appropriate to do so. I had a client one time that was referred to me, and the mom came to see me because her 9-year-old was having problems with food, and I do eating disorder work. And so mom was describing what was happening. What was really clear is that this child was experiencing problems to do with her sensory processing, and that it had little to do with her believing that she was fat or wanting to restrict because of any myriad of reasons, but rather that she was having difficulty with the texture of food in her mouth and the way that it felt. And so we were able to make a referral to an occupational therapist who was able to work with the family on how to be able to help her learn how to eat in a way that felt safe and was more appropriate. So part of what I do for a living is I become really, I do a lot of networking. I meet a lot of people and I find out what they have to offer, because oftentimes they are the people that I need to learn how to refer to. I had a client the other day that told me that one of the things that she appreciated about me is that my ego didn't get in the way of making a referral to her, for her when I knew that I couldn't provide the best care. She had multiple personality disorder, dissociative disorder, and I don't have a specialty in that. That's a very complex mental health disorder, but I have a colleague who does. So I referred her there because I knew that Donna would be able to help her better than I could. That's not because of what I'm not, it's because of what it is that I am willing to be, and that I am able to acknowledge what it is that I do well, and what I can learn to do better, and what probably is not my area to be working within. So as you take this class, I invite you to take a look at some of the different areas that are available for doing counseling. I love talking about being a therapist. I have gotten up every day for 30-something years and gone to work loving what I do for a living, and not very many people get to do that. I get to see miracles occur on a daily basis. I get to be part of those miracles, but I don't make those miracles happen. The clients do that for themselves. So I really encourage you to take an active look about how we serve people in the best way possible so that our clients are able to develop a life that's really worth living. Welcome to the class. I'm excited about it. I'm looking forward to getting to know you. And please know that I'm here if you have any questions. Thanks. Take care. Bye-bye.